Assalamu alaikum. A very good morning to everyone. My name is Dr. Wajiha Wakar. I am the moderator and I'll be the guiding session today of Preventive Cardiology, that is session 3. May I now request the respected and the esteemed chairpersons, I will call the names one by one, and I request the chairpersons to remain, please be seated on the rostrum. Thank you. May I now request Commandant and the Executive Director, Worthy Major General Nasir Ahmed Samoor, Professor Cardiology. Sir, please come forward. Thank you, sir. May I now request Dr. Nawaz Lashari, who is a Senior Consultant Interventional Cardiologist, to please come in front. Dr. Nawaz could not make it. Okay, may I now request Dr. Fasi Hashmi, Senior Consultant Interventional Cardiologist. Thank you, sir. May I now request Dr. Shahid Abbas, Senior Consultant Interventional Cardiologist. Dr. Khalda Sumro, Professor Cardiology and Senior Consultant Interventional Cardiologist. Ma'am, please take your seat. Dr. Amber Ashraf, Senior Consultant Interventional Cardiologist. Unfortunately, she could not make it due to her ill health. May I now request Dr. Azhar Ali Chaudhary, who is a consultant interventional cardiologist and medical specialist and also assistant head of department Preventive Cardiology, AFIC. Each speaker will have 8 minutes for their talk, and may I please request to please remain limit the talk time in 8 minutes. I would really appreciate that. Thank you. So let's begin with the first talk of the today. Our first speaker is Dr. Ahmed Fawad, who is Professor and Head of Cardiology and Director Cath Lab Services at Northwest General Hospital, Peshawar. He will be discussing a very interesting topic today, that is hypereosinophilic syndrome in cardiac patients, which is a very serious condition and that can lead to cardiac dysfunction and morbidity. So kindly, can you please come for your talk?
Bismillah ar-Rahman ar-Rahim. Strictly speaking, this is not preventive cardiology. I don't know how it ended up with this session. It should have been in heart failure session, but nonetheless, it will give you some change from the non-glamorous preventive cardiology. This is a story of a young chap from across the border, Afghanistan. He was sent to us with few months history of breathing issues. He had a cough, breathlessness, shortness of breath. His exercise tolerance was grossly reduced in the last few months. And on top of that, he has some dermatological changes. He has itching, swelling, and burning sensation and redness of his toes and fingers. He was erratically given some steroids locally with some painkillers, non-steroidals, bit of anti-allergics, bit of antibiotics doses. However, he remained very sick, very unwell, and he was brought to us in wheelchair. When we examined him, he was quite tachycardic. His venous pressure was raised. His lungs was full of crackers up to the mid zones, and he had 2 different distinct systolic murmurs. And on clinical suspicion, till so far, we thought probably it's a pretty straightforward heart failure. This was his initial outpatient echocardiogram that showed 4-chamber dilatation, particularly LV and RV. And there was significant wall motions abnormalities, particularly the mid-LV and the apical part, almost hypo to akinetic, and there was some organized LV clot. We could see 2 distinct regurgitant murmurs across mitral valve and tricuspid valves. However, things started changing when we initiated few blood tests, and the complete blood count came out to be having very high significant eosinophil count, more than 17. And subsequently, we requested a bone marrow examination that confirmed the findings. And although there were no blood cells, there was active myelopoiesis was going on. However, there was eosinophilic hyperplasia. Hematologist was involved on board, and he requested bone marrow biopsy, which confirmed the bone marrow examination, and it was showing 70% eosinophils. Subsequently, it led to a series of other investigations, including some cytogenetics, particularly FDG, FRA, and FIP1L1 mutations. However, this chap was negative for that mutation. As a part of diagnostic criteria for hypereosinophilic syndrome, you have to exclude secondary cause of eosinophils. So we requested stool examination to exclude parasitic infections. His IgA levels were checked that were within normal range. And to exclude his vasculitic component as a cause for his hypereosinophilia, we requested C-ANCA and P-ANCA levels to exclude the Church-Strauss and other vasculitic problems, but they were negative. He has tummy swelling, bit of tenderness, so we requested an ultrasound to look into the abdomen. However, that confirmed more or less the same changes as consistent with the decompensated heart failure. A pulmonologist was involved because he had breathlessness, cough, and on occasional hemoptysis. He requested HRCT that showed bilateral necrotizing consolidations, particularly involving the bases of the lungs. He has bilateral pleural effusions, more pronounced on the right side. He was admitted. He was put on heart failure therapy. Clinical hematologist and pulmonologist was on board. And meanwhile, we requested a cardiac MRI to look more on the anatomical details of the heart failure. And that showed classical LV mid to apical endomyocardial fibrosis and thickening, which could be related to hypereosinophilia. He had biventricular reduced functions, systolic functions. Ejection fraction calculated was around 40%. He has, as I mentioned on echo, he has both RV and LV enlargement, and there was a thrombocyting in the LV apex. There's a mild pericardial effusion, and right-sided pleural effusion was also noted on cardiac MRI. And as the findings on the HRCT, there was bilateral lower zone pulmonary consolidations, and quite few of them were necrotizing. These are the changes in the LV mid part and apical part with the signals coming from the endomyocardial fibrosis. A diagnosis of hypereosinophilic syndrome with predominant cardiac involvement was made. There's a list of differential diagnoses. I won't go into the details and I won't bore you with that, but it includes allergic reactions, asthma. We are all aware of those causes of hypereosinophilia, and most of them were negative in this chap. He was initiated on standard anti-heart failure therapy, including beta blockers, ACE inhibitors, and bit of a diuretics. And he responded well. Hematologist wanted him on steroids and hydroxyurea. This is the WHO consensus criteria for hypereosinophilic syndrome, where you have to demonstrate hypereosinophilia more than 1.5 on two separate occasions, at least a month apart. Along with that, bone marrow examination should show more than 20% nucleated cells of the eosinophil origin. Secondary causes needs to be excluded, and you have to demonstrate an organ damage which could be attributable to hypereosinophilia. Cardiac manifestations, I will quickly go through it, that it typically happens in three stages. The initial stage is the acute necrotic stage, where usually the clinical symptoms are minimum. However, if the necrosis is huge, it can create some symptoms. And then the second stage is thrombotic phase, and the later stage is the fibrotic stage, or the endomyocardial fibrosis, which brings most of the symptoms, particularly of the heart failure, in form of breathing issues, dyspneas, and chest pains. Cardiovascular management usually involves the heart failure therapy. However, there's a little bit of a difference when the valves are involved and there's a significant regurgitant murmurs, and if this patient indicates a surgical replacement, even despite young age, we don't go for the mechanical valves. Bioprosthetic valves are preferred because this is a very hypercoagulable state, and maintaining a good anticoagulant state in mechanical valves becomes very difficult in these patients. So bioprosthetic valves are the standard therapy in these patients. There are a series of medications, usually hematologists are involved in this, and this includes glucocorticoids, tyrosine kinase inhibitors like imatinib and mepolizumab. Usually they are given for FIP1L1 and FDGFRA mutations positive patients. There are some interferons, however, they are all second-line agents. Elimizumab is anti-CD52 monoclonal antibody, but as I said, these are given in cases where these are resistant or low responder to steroids. This is, by and large, a progressive disease. Prognosis is not good, particularly if there is an underlying secondary cause, including myeloproliferative disorders, particularly the acute myeloid leukemias, or if the TSE count is very high, more than 90,000, that brings a bad prognosis in these patients. Prognosis can be improved if there is an early detection and aggressive treatment, particularly with tyrosine kinase inhibitors, as I mentioned. There are certain features, if they are present in your patient, that can bring some good news in the form of a comparatively good prognosis. That includes presence of angioedema, urticaria, high IgE levels, a sustained response to the steroids, and early diagnosis and intensive therapy, particularly of the heart failure. Thank you.
Dr. Ahmed, Dr. Ahmed Fawad, what is the incidence? Dr. Ahmed.
Sorry, yeah, sorry. I was looking for you there. Yeah.
What is the incidence reported in the literature about this heart parasympathetic syndrome?
Predominantly, this is a male disease. It's a 9-to-1 ratio. If you go with the gender discrimination, it's a male disease, particularly in young age. Incidence, I can't give you numbers exactly given, particularly in our part of the world. We don't have data on that. But prevalence is more common in male population. Sir.
It takes me back about 30 years when I saw my first case, Loeffler syndrome. That was about a 60-year-old man who presented to us with heart failure and similar sort of a story. I remember at that time, diastolic dysfunction was probably the predominant picture of that, but then he went into heart failure. And we treated exactly at that time with diuretics, and we did not have at that time all the Ayashi of vasodilators. That's 30 years ago. And the gentleman was about 60-year-old, and he survived till sort of I left the place. So this is the second case. So it's not very, very common. It's not a very common illness, but it needs proper diagnosis and proper treatment, and it behaves like a malignancy if left untreated for a long time. Thank you for the presentation.
Thank you.
Sir Ahmed, it was a very nice presentation. I would like to ask about the cardiac biopsy. Did you think of it?
Cardiac biopsy in the guidelines, in the algorithm is not indicated because the diagnostic criteria from the WJ consensus statement is that you have to demonstrate eosinophil count peripherally and in the bone marrow. You have to exclude the secondary causes and in organ damage, either in the form of cardiac MRI or CT, if you can demonstrate non-invasively, so you don't need to do cardiac biopsy.
Thank you very much.
Thank you so much, Dr. Ahmed Fawad, for such an insightful presentation. Our next presenter is Ma'am Sidratul Qudsiya, who is a clinical dietitian and a very, very important member of Team Preventive Cardiology AFIC. Her topic is nutritional management of diabetes, which is a very, very serious risk factor for CVD. She will present some guidelines, and by following these guidelines, we can effectively manage the patient with diabetes. Ma'am, can you please come in front for your talk? Thank you.
slideshow पे लगा दूं? Myself, Sidratul Qudsiya. I am a clinical dietitian and specialized in human nutrition and dietetics, which is very emerging field. I am also part of prestigious FIC, which is an unparalleled institution for its excellence in healthcare system. Today I will talk about diabetes. It is basically a metabolic disorder in which body is unable to metabolize carbohydrates. Being dietitian, we will work on risk factors, either modifiable or non-modifiable. For modifiable, we will prevent the risk factors, and for non-modifiable, we will manage the risk factors. So what role a dietitian will play in this regard? Basically, we will provide a nutrition care process to the patient in which we do proper assessment. We make nutritional diagnosis and we do nutritional interventions under the umbrella of nutrition care process. We also motivate and encourage the patient through the proper monitoring and evaluation. Here are some causes of diabetes which are nutritional basis. They have some of nutrients are written over here which are directly or indirectly involved in causing diabetes. For example, B1 vitamin is involved in glucose metabolism, which is glycolysis, and if this vitamin is deficient, then the body is unable to metabolize the glucose. Similarly, iodine is another important nutrient which is important for the thyroid hormone secretion. If it is deficient in our body, then the body is unable to regulate the metabolism. Again, the fiber is very important. If the patient is not taking a good amount, which is 25 to 35 gram per day, then patient will face the insulin resistance. What are the goals we decide during the management of diabetes? We basically emphasize on the blood sugar control, and we want to minimize the glucose spikes during the intervention. Another challenge is weight management for us. Both the underweight and overweight individuals are very important for us, and managing the weight is very important. Because we want to reduce the risk associated with diabetes and also the diabetes related complications. Here are some dietary regimes we follow in this regard. First of all, we will provide the diet therapy alone. If the patient recover, then we will go with this. And in other case, if the patient is not recovering well, we will also refer the patient to the medical specialist or the endocrinologist for their diet therapy as well as for medicine or insulin. Another important thing which we will take into account is carbohydrate counting. Carbohydrate counting is basically important for pre-diabetic patients, in which we will have a proper check and balance for counting the carbohydrates. And if the patient is suffering from type 2 diabetes mellitus, then we will do a proper consistent diet plan. For which we do the fixed amount of carbs. For example, the patient is taking 50 grams of the carbs in the morning in the breakfast. We will advise the same number of carbs in the lunch and as well as in the dinner as well. The reason behind this is to minimize the spikes in the glucose and to train the body for the metabolism of glucose. If the patient is on insulin, then the calculation is somewhat different. We will calculate the carbohydrate according to the units of the insulin prescribed to the patient, and we will apply some formulas. We will calculate the insulin sensitivity factor. We will calculate the insulin to carbohydrate ratios. Here is a successful case. The patient 6 months before has visited to me. That time her weight was 108 kg and now her weight is 78 kg. Waist was 47 at that time and now the waist is 38 in the previous week. HbA1c was 6.3% and now the HbA1c is 5.8%, and I want to mention very proudly here, I have done all these with the help of just diet. And BP was 180 by 120 at that time, and now the BP is in the normal ranges and hemoglobin is also have been improved. Here are the reports of my patient. This is another case. Mr. Wazir Hussain has visited me in December, and now his HbA1c value is 6.5 and 5.8, and that time his HbA1c was 6.5, and this also have been done with only diet therapy. Thank you. Any question, please?
Excellent talk. May I request that the patient's privacy should be respected and preserved. So please do not put in the names, remove the names. But what you have achieved, you didn't tell us how did you achieve, how did you do these miracles? When you brought the weight down, how did you was it only diet or did you use Ozempic or what happened?
Sir, lifestyle changes are very important, like physical activity and other thing, which is the diet. Diet is very important. It plays a miracle role in the life of the many patients. These are the only 2 cases. I have done lot of cases in which I have bring lot of changes just with the help of diet.
So, do you use keto
I think
diet
it's lack
or
of
you
diet, then diet.
promote keto diet?
Lack of diet.
Excuse me, it was a very well presentation. But what I would appreciate you, and especially I have no words to say, that how did you bring 180 blood pressure of systolic to 120 without any drugs? Please, can you
Sure, sir.
elaborate?
Actually, I have used a combination of 2 diets. One was the DASH diet and other was the Mediterranean diet. By combining these 2 diets, the patient was able to reverse his condition.
Ma'am, I think your presentation was very good, and I think it's very admirable that the nutritionist is there to help the physician also in management of these patients with diabetes. However, when you are talking to your patients, how do you motivate them to be able to reduce their weight, to be able to reduce the intake of food, because this is something which is very difficult
Yes.
and time consuming.
Yes, sir. Sir, being part of Preventive Cardiology department, I am very honored for this part of team. Sir, we do this by enrollment of the patient. We do proper sessions of the patient after every 2 weeks, and proper follow-up is very mandatory for the patient. We enroll the patient for rehabilitation, and also we done with proper monitoring and evaluation. And we also offer some prizes or the rewards for the patient with the some improvement.
Well, you talk of the diet, Mediterranean, Pakistani or whatever, for a common average individual, how would you say that? What kind of a diet? I want to know in simple words. Dal khai, roti khai, chawal khai, kya khaya? Simple language.
Sir, high fiber diet. क्या
बताएं
खाया
ना मुझे,
ठीक है
हम जानना चाहते
सर
हैं।
हमारी अगर हम कुदरत में अगर सादा अल्फाज में बात करूँ तो ताज़ा कुदरती ग़िज़ाएँ जितनी भी हैं अगर हम उनको यूज़ करें तो हम अपनी बहुत सारी लाइफस्टाइल की जो भी अचीवमेंट्स हैं उनको
Can
कर
we
सकते
please
हैं
proceed to the next
The
talk
last,
because we are
last
short of
question.
time.
Last question. Last question, please. Ma'am,
Sir, actually, we are running short of
at least
time
last
for the next
question.
session.
No, the question is that is diabetes only a glucose control, or is it only because of the lack of insulin or less insulin, or there are a lot of things in it, vascular disease, metabolic disease, other things. How can you cover it with the diet only and control the glucose and control the diabetes?
सर
Diabetes is an inflammatory disease or something. It is very difficult to understand.
sir if it is inflammatory we also provide anti-inflammatory diets as well
Anti-inflammatory diet.
yes sir
Is it there any?
Sir,
Yes,
actually,
sir.
excuse me, sir. Actually, physicians are working along with them.
Thank
Thank
you
you
so
very
much.
much.
So-
Thank you very much for answering it.
Thank you. Thank you so much, Madam Sidra. That was such an insightful and a very, very valuable talk. And thank you for sharing your expertise with us. Thank you, Madam. Now we move on to the next session of today, and that is very, very important. And it goes without saying that it is the part and parcel of prevention, and that is cardiac rehabilitation program. For that, I would like to invite Madam Mariam Zahid, who is a clinical dietitian and public health expert at FIC for the last 10 to 12 years. Madam, can you please come forward and have your talk? Thank you.
Assalamu alaikum. I am Mariam Zahid and I am a clinical dietitian and a public health worker. My topic is cardiac rehab as a dedicated clinical service. What is a cardiac rehab? It's a complex intervention that is offered to a cardiac patient, which includes the health education, advice on cardio risk reduction, dietary intake, physical activity, and the stress management. Do we really need a cardiac rehab? Yes, thank you, sir. This we will discuss over the weekend and again and again. CVDs are the leading cause of mortality globally, with deaths and disabilities. And in 2021, only CVDs were accountable for 20 million of death. That is approximately 1/3 of the total death. So we were thinking, acha, 1/3, so it will be like high-income countries, developing countries where they have sedentary lifestyle, where they can afford junk. But sadly, that is not the case. Around about 3/4 of CVD deaths occur in the low and middle income countries. So, and we have plenty of data that shows that how cardiac rehab helps to prevent the complications of CVDs, how it helps in recovery, how it reduces the readmission of the patient. Multiple diseases are research papers are available. But why cardiac rehab? First of all, unfortunately, Pakistan GDP only has 2.8% of the healthcare facility, right? And at least if to achieve that SDG for health for all, we need 5% of our GDP to be serving the healthcare. Okay, so we don't have that financial opportunities, and if we stay away from the cardiac rehab, these readmissions is going to create a problem for us. And for recovering of surgery and procedure, once the procedure is done, patients think, "Bhai, they'll change ho gaya, we don't need any kind of intervention, now we can eat anything, now we can rest, now we can go to our lifestyle, previous lifestyle." At that point, the patients need to know, "Ke bhai, now you have to start the lifestyle modification for the exercise, for the stress, the reason the problem was caused, ab usse theek karna hai." Okay, for that, cardiac rehab is required. And to increase the quality of life, multiple researchers have published how the cardiac rehab helps to increase the quality of life. And in the secondary prevention, if the patient comes with us with the obesity, with the hyperlipidemia, so we can do early diagnosis and we can start the prompt treatment before it makes to the complication. So who gets benefit from it? All the ACS patients, patients with MI, ST elevation, non-ST elevation, chronic stable angina, post-chronic heart failure. Then after procedure like cabbage, valve surgery, percutaneous coronary intervention, cardiac transplants, and also the patient that has no cardiac disease but have hyperlipidemias and obesity, diabetes that are coming to the rehab department or referred to the rehab department. So our team in AFIC has a preventive cardiologist. Together with the cardiologist and a surgeon, we have a team which has a preventive cardiologist, a clinical dietitian, a psychologist, a physiotherapist or an exercise physiologist, a pharmacist, and a public health and a research worker. This is a whole team we are working together for patients. So what actually patient does? It is referred by a surgeon or a cardiologist to the preventive clinic, where we have a preventive cardiologist that assess the risk of the cardiac risk, then makes a patient care plan, and then refers to according to the patient's need. It refers it to the clinical dietitian or a psychologist or a physiotherapist or a pharmacist. So this doctor decides. Then what are the services we are offering in AFIC? One is pre-discharge awareness lectures. When the patient is discharged, twice or thrice a week, depend upon the availability of the auditorium, announcements are made. Trainees go to the wards to tell the patient who are discharged that you have to come to Zulfikar Auditorium. A presentation is ready with this team, and they present a educational program in which they tell a basic about diet, stress, tobacco, everything to the patients. And if they have any questions, they can ask during the presentation. And if they want a one-to-one counseling session, we offer them post the session. Okay, this takes place twice or thrice a week. Then pre and post cardiac rehab. When a patient goes to the preventive cardiologist, it notes down its blood values, medical history, pre-cardiac rehab program that take place around about 3 to 6 months depending upon the patient's condition, right? So it takes this thing, okay? Cardiac risk assessment is done by the preventive cardiologist, which uses European Society guidelines. Then there is a tobacco intervention program that Dr. Vijaya will discuss, in which we reduces the nicotine dependence, and then if the patient is having nicotine effects, after that we also manage that. And we have lots of successful cases. So dietary consultation regarding the warfarin use, obesity, sodium reduction, and then diabetes, we offer that in this department. Stress management is done by a worthy psychologist, and that includes the CBTs, that is cognitive behavioral therapy, then emotional therapies, and then INR and heart failure clinics, although they are proposed, but the pharmacists are working on that for the patients in education. So the barriers we are facing is the lack of referral. For that, we go to the wards to encourage patients to come to the cardiac rehab patients. Announcements are made, but still we are facing that lack of referral. The resources related to NRTs we have to import it. That resources are having problem, and then access to transport. Thank you so much.
Thank you very much.
If there is any question and answers, the floor is open.
Cardiac rehabilitation is an extremely important aspect of treating our patients. And it was very heartening to see that there is a heart failure clinic or rehab unit which is proposed. And I think it should be done urgently, because this is the fifth pillar in the treatment of patients with heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So in all these, across the spectrum of ejection fraction, cardiac rehabilitation in these patients is of extreme importance. The other thing is that whenever you have these, for example, you have a unit, and I remember General Zulfikar actually started this preventive aspect there, cardiology at the Armed Forces Institute of Cardiology. What you need is that you gather your patients on one day and you talk to them.
Yes.
And this is how you're going to motivate them. You have the psychologist with you there, because this is when you have a joint meeting with them, you will find that they are more motivated to follow the program, and then every day you should have the rehab program where you have graduated exercises for these patients to do, and also some aspect of sports in it. For example, there can be a badminton court there which can be used for these patients. They can have tennis also. They can play tennis, but with a smaller, with a lesser, heavier rackets. And the ball is also lighter in these cases. You can do that. You can put them through swimming, and you can telemonitor them. So these are the things which you should actually be doing for cardiac rehabilitation, and every tertiary care hospital in Pakistan should have a cardiac rehab unit.
Yes, sir.
Sir,
Thank
I
you so
think
much, sir.
It's very heartening to see that. I've been pushing this preventive department for a very long time. And I said that if a hospital has got one cath lab, it should have a small department. But if a hospital has 2 or 3 cath labs, it should be reflected in their preventive department as well. Just 2 small points. I think instead of having formal lectures, if you have already tele-recorded sort of things and you can play it while the patients wait for the doctors to be seen. So all over in your waiting areas, if you can play these videos, one. Second, you can utilize something which you did in Peshawar, and that was a constant relationship with your discharged patients, and that is through the SMS service, which is very cheap, which is very easily available, and you can even send them small messages and recorded voicemail messages, which are extremely helpful.
Sir, excuse me, sir.
Sir,
All
thank you
these
so much.
proposals which you have
Sir.
just given, they are being practiced in
Sir.
the FIC actually.
Excellent.
All around OPDs and outside the cath labs, we have short videos which are playing all the times. Thank you, sir.
Excellent.
Thank you so much, Madam Mariam, for such a valuable talk. Thank you so much. So now I would like to grasp this opportunity to present my topic of the session, and that is really important. That is smoking cessation, which we all know is very important. And I'll be talking about the tobacco intervention program, which we have already started in Armed Forces Institute of Cardiology. Of course, all of us know about that the smoking is a really very serious risk factor for the primary and the secondary
You
prevention.
are already
also.
short of 2 minutes.
Yes, sir. So I'll just make it quick. The fact which I want to elaborate and I want to reinforce in this lecture is that the tobacco and the nicotine, they both are same, and basically the tobacco is the plant and the nicotine is the product that is present in the leaves. This presentation. So basically, we'll be talking about how we are taking our patients and how we are doing the tobacco intervention program in AFIC. We all know the hazardous effects of the tobacco on our life, so I'll just quickly skip the slides and we move on. So basically, this is the pictorial diagram that shows how your lungs take a transition and how your respiratory system transit and then move on to the normal healthy lungs after you quit tobacco smoking. So the first diagram is the black one, and the last diagram is when your lungs fully replenish when you quit smoking. And this is the miracle. Within minutes, hours, days, and months it happens. So basically, what we do is, we follow a 5 A's model for tobacco cessation. First, we ask these, I will reinforce that all the trainees and all the cardiologists, our senior cardiologists also, they follow this model. This is very important and internationally recommended by AHA. First of all, these are the 5 A's. First, we should ask each and every patient, regardless, that whether you smoke or not. We have to assess the patient is willing for tobacco smoking or not, and that is really important. We have to advise regardless patient willingness for quitting the tobacco. We have to assist the patient for quitting, and for that we make a quit plan, which I'll discuss later. And then we have to arrange the follow-up sessions with the patient. That is really important, because in this case, the motivation is the real guide. And if you do not motivate your patient, or if you lack something, then your patient will not come to at the end of the follow-up sessions. So for that, we follow a regime that is the first line medications. It is worth mentioning here that these medications are not available for over the counter. These medications are available in few cities of Pakistan, and we are arranging many meetings, and we are working that these will be readily available in our institute also and many others. So basically, the nicotine replacement therapy has two domains: the NRTs, patches, gums, lozenges, I'll discuss it later, and the non-nicotine medications that involves the oral varenicline and bupropion. The reason for using NRT is that NRT is much less addictive than the cigarettes, and it helps your patient to cope with the withdrawal symptoms. It makes your patient more comfortable and treats the withdrawal symptom of your patient. And it gives the nicotine, which is very, very clear and harmful of the toxic chemicals that tobacco gives you in cigarette or any non-tobacco forms. Coming to the patches, the nicotine patches, they provide a steady level of nicotine in the body. They can be available over the counter. They have got a good compliance. If the patient, you assess by following a Fager-Storm score, that is a very, very good AHA-approved score. I have not mentioned it here because it will be too long, but we score the patient on that score. And if the patient comes in low to moderate, moderate to severe, and high, then we treat accordingly. So in that slide, you can see less than 10 cigarettes per day, then we give 14 milligram patch. Greater than 10 cigarettes per day or more than half pack, then 21 milligram patch. And that is very easy to apply, and it works for 16 to 24 hours. The nicotine gums, they are very good. They are patient-friendly, and they help reducing the cravings. But they have certain side effects because you have to follow certain method, which I'll discuss later. And if the patient, again, these are the strengths which the patient have. The main thing is that you have to tell the patient that chew them and then park inside your gums. And then when the taste fades, then again chew it. This is very, very important, and we have to make our patients aware of this thing. Then lozenges, you can also use them. Of course, if the time to first cigarette is less than 30 minutes, then you give 4 milligram. And if the time to first cigarette, TTFC, is greater than 30 minutes, then you give 4 milligram. Then certain sprays are also available, and they are very, very efficient. They can be used 1 to 2 doses per hour or 2 hourly. But fewer side effects mentioned, but they are not worth mentioning because the benefits are much more. The risk benefits are much more. Then the Velo pouches, they have not approved to be used, but they are not harmful for the patients. They can be used. Okay, the nicotine withdrawal symptoms, basically this is our challenge, and we have to overcome this challenge. These are certain symptoms for the nicotine withdrawal, and these are the symptoms which motivate your patient to restart smoking. Coming back to tobacco intervention program, and this is very important, I'll just quickly tell you, we have started a tobacco intervention program in AFIC based on the nicotine replacement therapy. A patient came to us, 53 years old male, had a history of 34 years of smoking, and he was smoking 10 cigarettes per day. According to the score, he had moderate nicotine dependence. He also had fewer attempts of abstinence from the smoking but could not be successful. He was actually really motivated to quit smoking. So what we did, we planned it with our team, the multidisciplinary team that included, you have already seen, and I'll also mention it, many, mashallah, good members of our team. So the plan was started, and it was on the 2nd May, and the patient was given gums and the patches. And a WhatsApp group was made that include cardiologists, nutritionists, pharmacists, and psychologists. And at the end, I am really feeling very proud saying that the patient quitted smoking fully on 19th May, exactly after 3 weeks of our plan. So in the conclusion, the nicotine replacement therapy is really, really important. What it does, it helps treat your withdrawal symptoms, it helps by reducing craving, and it enables the patient to feel comfortable and concentrate on the other psychosocial treatments which we provide to the patients. Basically, the patient adhere to those treatments if we give NRTs, because the withdrawal symptoms will not be there and the patient focuses on the treatments which we provide. Thank you so much. So I would appreciate if there are any questions, and then we can move on to our next session.
Just one short
Sir.
question. Smoking is one form of tobacco dependence. What about the other, like
Sir.
niswar or the kuch
Sir.
tobacco khate hain pan mein?
Sir, it's a very good question. Thank you so much for putting it in. Sir, we are also working on that. And for the Naswar, we have we have collected many cases, and our very senior cardiologist also, she's not here, but she has done many, many remarkable cases, Dr. Shazia. And for Naswar is a smokeless tobacco. And tobacco is not something that can smoke. There are many smokeless tobacco that are harmful, and I always tell my patient that the Naswar addiction is much hazardous, because when you take Capotin, you get it sublingual, so it absorbs quickly. You take Naswar, it absorbs because submucosal absorption. So this sentence, it is very, very important for the patient. And when I give pre-discharge lectures to the patient, I make sure to deliver this sentence. So, sir, we are working really hard on the Naswar addictions also, even many other forms also. Sir.
Increased incidence of the ectatic arteries in the people from the KPK is mainly due to the oral chewing Naswar.
सर एक टाइम था कि हम लोग नस्वार कैचर्स मशहूर हो गए थे.
अच्छा, इसमें पनाने में खैर आई थिंक एज फार एज स्मोकिंग सेसेशन इज कंसर्न बहुत काम किया है. पाकिस्तान कार्डिक सोसाइटी भी करती है. हैव यू ट्राइड दैट टू कन्विंस द गवर्नमेंट that they should increase the tax on nicotine and nicotine products, so that will also reduce the purchasability of this product, and that probably will also help reduce smoking.
Sir, thank you so much for putting this question, sir. Last week, I delivered a lecture on behalf of PANA in AFIC. Our respected commandant was also there, and there was a souvenir made, and it was presented to the government last weekend by PANA and by Dr. Sanaullah Ghuman, and it was written precisely in that souvenir that we will make a resolution for this tax involvement also. So, sir, it has been done by Dr. Sanaullah Ghuman also.
Just a comment, sir, about this taxation in tobacco. This was done in Malaysia also. And actually in Pakistan, there are just two big international tobacco cigarette makers. And they pay 90% of tax because they cannot avoid it. All the rest of the local tobacco makers, they write a retail price and they are ready to sell at a much lower price. And 90% market is captured by those guys. So if you keep on increasing tax, what happened was earlier they started taxing at the processing side where tobacco is sold. And everybody went on strike, all the senators, because then the taxation was uniform. And then it was removed and sent to the retail at a sale price. So what's going to happen is keep on taxing them. And in Malaysia, those two companies left the country because they were like they couldn't make ends meet. Please, this is very important. Give me a few minutes. You've got to get this thing right. You keep taxing them, they will eventually leave and there will be no taxation and you're left with the mercy of these local brands. So it has either to be taxed at the processing of tobacco side, where then every person who buys tobacco will have to pay a tax, or make it reasonable, because those who do not pay tax, they don't mind selling a 700, 500 thing at 300. They still make a lot of profit. So that's something you must remember. We keep on foolishly thinking, I would say foolishly thinking that putting tax on it, make them expensive, will make them prohibitive. They will not. They will just encourage the people who dodge the tax and illegitimate dealers.
So thank you so much, sir. We will make a consensus with the PANA and try to do much more better. Thank you so much, sir. Now we move on to our next session. That is very, very important. As we know that the primary PCI in the remote areas is very, very difficult due to certain challenges, the transportation time and limited access to the catheterization laboratories and difficulty in maintaining the consistent chain of care. And that's why we included this session, and we move on to the next presentation. For that, I would like to call Dr. Umar Yusuf Zai, who is a senior trainee cardiology at Sadhu Group of Teaching Hospital, Sawat, and he is also a second prize winner at Cardiocon Sakkar. He will be highlighting the statistical analysis on the primary PCI. Sir, can you please come forward and have your talk? Thank you.
नहीं बस ठीक है अभी नहीं अस्सलाम वालेकुम अस्सलाम वालेकुम I am Dr. Umar and a PG, a postgraduate resident at Cardiology Unit, Sadhu Group of Teaching Hospital, Swat, and I am here to present on behalf of my Cardiology Unit, Primary PCI at Cardiology Unit, Sadhu Group of Teaching Hospital, Sawat, a statistical overview. So the story of our unit indeed aligns perfectly with the theme of this conference. Yes, we have pushed boundaries, we have recent advances, and we have a lots of future frontiers. So before jumping to the statistics, I would like to share a few things from the past. In 2011, we had a small setup, one ECG machine and 2 qualified FCPS consultants. 2016, we got an ATT and echo machine. May 2021, we performed our first electroangiography. With PCI. October 2022, we started primary PCI at Sadhu Group of Teaching Hospital, Sawat. From October 2023 to mid-March 2024, most of the institutes were not entertaining primary PCIs due to SSP issue, but we entertained. In 2024, now we have 16 qualified cardiologists, half of them are interventionists, an electrophysiologist, and 1 feeds cardiologist. We are recognized for the postgraduate training, and fellowship in intervention will be starting soon. These are the areas we are covering, and we entertain patients for the primary PCI from these areas, which include, you can appreciate, these are the remote areas, Kalam, Kohistan, Shangla, Malakand, Dir, Bonir, and a lots of tourists as well. Since May 2021, total procedures were done with 3,500, with left heart catheterization 3,300, 200 TPMs and 11 PTMCs were performed there. Among left heart catheterization, 1,700 were PCIs, 1,500 angiographies. Primary PCIs counts 572, with elective procedure 1,171. So this is our route map to establish the flow. Basically, our hospital consists of 2 wings. In one wing, we have our chest pain clinic, and in the other wing, we have a cath lab. As soon as a patient comes to the chest pain clinic and the doctor on duty recognizes it as a STEMI, so this whole system activates, and one focal person designated specially for the shifting of the patient with the ambulance shift the patient to the cath lab immediately. Despite this 0.9 kilometer distance, we are trying best to achieve the shortest possible door to balloon time, which is 87 plus minus 10, with evening 81 minutes and morning 85 minutes. Here I have shared a screenshot from our primary PCI group, where you can appreciate that a patient came with STEMI at 10:54 a.m. and within 41 minutes the flow has been established. Among the primary PCIs, 93% were accessed with the radial, 5% with femoral, and 0.5% with the brachial. When it comes to establish the flow, 86% DEST were deployed with 3.9% drug-eluting balloon, 7% FOBA, and 2.48% were recanalized spontaneous. When it comes to the segregation, the culprit artery LMS was involved 2.6% with 41.7% LED involvement, left circ was 25.8% and 29% RCA involvement. Yearly distribution of the primary PCIs, 41% was performed in 2022 to 23 with 17% rise in 2022 to 24. Regional-wide distribution, you can appreciate that Swat has leading the primary PCIs, 40% which is followed by Shangla, Buner, Swat, and 5% tourists were entertained with the primary PCIs. Age-wise distribution of the primary PCIs were 41% with the 56 to 70 years age and 7.1% with 18 to 40 years of age. Gender-wise distribution was female with 32.3% and 67.7% male were entertained. Comorbidities, amongst the comorbid condition of the patient who undergone primary PCIs, hypertension was leading with 46.9% and death in diabetes and dyslipidemia, prior heart failure and CABG and prior PCIs with 4%. Intra-procedure events, contrast reaction was leading with 0.9%, wire loss, perforation, hemodynamic instability, arrhythmias, and cardiac arrest. In-hospital events was heart failure with 0.7%, shock, re-MI, stroke, arrhythmias, and contrast-induced nephropathy, 5%. Primary PCI bleeding in hospital was led by the radial side bleeding being the most common 0.8%, then followed by radial side hematoma, femoral side bleeding and retroperitoneal bleeding with 0.2%. Our overall discharge rate is 96.3% alive with 3.7% mortality rate. These are our future frontiers which we want to establish as soon as possible. Our own cardiology institute, sir will agree with me. Our own cardiac surgery department, basically we are working part-time being now with a private setup which is in half-kilometer radius to our cath lab. So when there is a complication like perforation, retroperitoneal hematoma, so we work in collaboration with them. So we need our own cardiac surgery department. We need electrophysiology department, pediatric cardiology unit, satellite center. These are very important at Shangla, Buner, because when a patient from Shangla refer to us, most of the time he is late for revascularization. So we need a satellite center at Shangla, Buner, Malam Jabba, so that we can entertain the tourists right at these spots. Most of the famous celebrities we have entertained with the primary PCI, you can see these interviews on the YouTube and Koistan. These are our heroes which started from the zero, and we have our excellence now at our unit. I want to thank all of you and Cardiac Registry of Pakistan for helping us with providing the data. Thank you, sir. Any questions? Yes, please.
I think we are already late. With one short question.
This is basically what we call a dream coming into a reality now. And lest we forget, there were two cardiologists there, Professor Roshan Hilal, we should not forget him, and we should not forget Professor Nazir, who started cardiology, and it was in the 80s when the Pakistan Cardiac Society went there with, I think Abdul Samad Sahab was there, and then there was an excellent meeting. So probably those were the initial starting points from where you have now reached this part where you have a primary PCI program running very good in Swat, and I think it's very admirable. But we should not forget those who actually started it.
यस सर, एक्चुअली हम लोग अभी जो पाकिस्तान कार्डियक सोसाइटी की हेल्प से एंड इंटरवेंशनल कार्डियोलॉजी सोसाइटी की हेल्प से मुख्तलिफ वो अरेंज कर रहे हैं, जिसमें हम वो प्रीवियस जो मोस्टली रिटायर्ड हो गए हैं उनको एट्रीब्यूट देते हैं, उनको बुलाते हैं. बट सॉरी फॉर नॉट मेंशनिंग, नेक्स्ट टाइम आई विल मेंशन इट अगेन.
जितने प्राइमरी पीसीआई आपने किए हेल्थ कार्ड के थ्रू किए?
जी जी, most are SSPs and some are with personal payments.
And there's usually no affordability issue at all.
Affordability issue है, बहुत ज़्यादा है, इसलिए तो हम mostly 97% are done with SSP. Yes.
Right. Thank you very much.
I think same issues as anywhere else because you do not have access to a lot of funds. But the good thing about Swat is that all you cardiologists are working together. One, people are working in private cardiology, and Mahmood was sharing with me that there are good hospitals coming up with good standards like Luqman Hospital.
Yes.
And you all work together. So that's the only place I think in whole of KP where primary PCI is being offered in private center with the help of course, Sehat card. So excellent job. Wonderful.
Yes,
very proud of you.
Okay, thank you.
There are 5 cardiac center in the working in the Swat.
Yes.
Just a minor thing I just want to ask it, and excuse me, just a minor thing. You have just explained you have used the 0.5 of all of your statistics through the brachial access. So what was the reason for going to the brachial access apart from the radial and the femoral one? So other than this, I just want to congratulate you for your just great work in the Swat and at your working session.
I have mentioned that there were patients with the previous MIs, and my supervisor is just there. He can explain it better than me. Sir, please.
Thank you, everybody. I'm Dr. Hadi from Sedu Teaching Hospital, Swat. I'm really humbled and thankful to this forum who provided this opportunity with a very short notice to accommodate our this presentation. I'm really thankful to Professor Hafizullah, my teacher, Professor Mahmoodul Hassan, Professor Hikmatullah Jahan for training us, and then we were motivated to go back to your areas and provide these facilities and these services in your particular area. Now, Alhamdulillah, this Swat Sedu Teaching Hospital providing these services to almost 10 million, over 10 million population of the Malakand division, which is the only government teaching hospital and tertiary care hospital for the whole of the Malakand division. Alhamdulillah, we are providing these primary PCI and elective PCI for the last more than 2.5 years, and the program is running smoothly. The only thing which I learned from this last 3-4 years is the teamwork. You need a very dedicated leadership, which is the visionary vision for the future as well, and all those things is the patient should be the priority. When you put all things aside and you put patient a priority, things go smoothly, and Allah also give you some opportunities as well. Thank you so much.
Sir, answer his question, please.
So please, would you repeat the question?
Thank you very much. I just requested, what was the reason you just went for the brachial access apart from having the femoral and the radial one? So kindly, can you explain that?
Most of the time from shifting from radial to some other axis is either the spasm or the very tortuous arteries, and you encounter some other issues at the radial axis. Although radial artery is by default the first choice for going in for the intervention, few things, in one patient which I still remember, the patient was basically from a religious point of view. She was a lady, and she was constantly refusing to refuse for the femoral axis, and although we had issue for accessing the radial axis, and there was some issue with the left radial as well. Then in that particular lady, we went for the brachial artery.
Okay, thank you.
Mike, madam.
Why woman patients ratio is less than men?
Less than half.
Exactly.
32%.
Almost there were 2/3 of the patients were male and 1/3 of the patients were female. Although we have no any policy discrimination, it may be by default and by chance that we are receiving the female more as compared to the female.
77 versus 26.
Yeah, but exactly we are alhamdulillah providing these services 12 hours a day from morning till night and without Sunday at the time for the time being.
It is
But exactly.
none of your fault, probably.
Yeah, exactly.
Can we proceed to the next talk, please?
Thank you, sir. Thank you so much, Dr. Yusuf, for such a thought-provoking and insightful session. Thank you very much, sir. Now we move on to our next session, and that is really very, very important. It's on meta-obesity. It's a term used to describe a cluster of disorders like obesity, insulin resistance, diabetes, and CVD. For that, I would like to call upon Dr. Rehan Umar, who is a consultant interventional cardiologist and head of cardiology department at Patel Hospital and National Medical Center, Karachi. Thank you, sir.
Assalamu alaikum, everybody. Thank you very much for inviting me here. I'm grateful to Asif Bhai for giving me this honor. In one simple answer to this question, just मैं अपनी presentation खत्म कर सकता हूँ कि is meta-obesity a fiction or a fact? The answer is yes. It is a fact, and the end. But I have to spend 10 minutes on it. Usually I spend 10 minutes on just the preamble of this talk because this is such an important talk. Preventive cardiology की meetings होती हैं all over Pakistan. People keep on talking about calcium score, CT angios, MRIs, but nobody addresses the core understanding, the core problem which our part of the world is suffering from, and that is obesity. And that is the main theme that I'll be talking and touching upon. To begin the talk, I think the best question at this point in time to ask the podium would be what the middle age actually is. So any thought from the audience what middle age is? 60. Any good idea, any better thought?
65.
65. Sir, okay, so, okay. So the correct answer would be, at this point in time, this is the middle age. Okay, so the middle age is when we expand from the middle, and for obvious reasons, this is the main thought process, the urbanization, that we like to go and we love to eat out. We love to dine out. And this urbanization leads to the destruction that ultimately leads to cardiovascular disorders and the high degree of sheer morbidity and mortality that it begins. कोविड के ज़माने में 3 साल पूरी दुनिया बंद रही, एयरलाइंस क्रैश कर गई, ऑफिसेस क्रैश कर गए. We all used to work from home, and we just don't forget the notion that the total number of mortality during that 3 years was 3 million. Just 3 million. पूरी दुनिया बंद हो गई. And at this point in time, when I'm standing on this podium, there are more than 530 active patients of cardiovascular diseases across the globe, and there are more than 21 million deaths attributable to cardiovascular disease. But that is the sheer gravity of the situation, and the core problem is the process of urbanization. If you look at this picture, I'm sure majority of us would know who this gentleman is. He is the most famous number 9er in the world, if anybody is interested in soccer. Ronaldo Romario, right? So he retired, and this is what became of him. See? So this is what obesity does, what bad diet does, what bad lifestyle does to our patients. Fake news, sir, this is the reality. Number one. Number two, I've got colleagues from my fraternity who are obese, and I simply ask those colleagues of mine with politeness and humble कि आप अपने पेशेंट से कैसे बोलते हैं कि आप अपना वजन कम करो. And you know what the answer that they give to me? हम बोलते ही नहीं. ठीक है, कैसे बोलेंगे वो? So we need to take care of that as well. So we need to work on obesity. So we need to define obesity first. So we know that we have the cutoffs which are absolutely different from the Caucasians. In Caucasians, if we look at the BMI criteria, the BMI criteria tells us that 24 is the cutoff. But for Pakistanis and Asians, we have 23 as the cutoff. And if we keep that cutoff in mind, 58% of Pakistanis are obese. 58%, more than 50% of Pakistani population is obese. That's the irony. So we need to take care of that as well. So we need to protect ourselves from the path of destruction. We know that we are dealing day in, day out with these chronic conditions, hypertension, diabetes, ischemic heart disease. So what we are dealing with in our clinical practice is multimorbidity. So majority of our patients, they have multimorbidity. So they do come to us. We all know that 86% of people with diabetes live with overweight and obesity. 31% of people living with obesity have diabetes, and 32% of people with diabetes have cardiovascular disease. So all these things are interlinked. We know that patient who has diabetes, clinically, he has 6 lesser years to survive. And that very patient has got diabetes with cardiovascular disease, 12 precious years of his life are lost. And if that patient also has kidney disorder, which is a part and parcel of cardiovascular armamentarium, then he has 16 years lesser to live as compared to the normal person. So this is what goes wrong. This is what happens in patients. We have an interconnection, an interlinked cardiovascular disease, kidney disease, liver disease, cancers, all are interlinked together. And we need to work and address all of these sharing comorbidities in a same very patient. And that brings me to the topic of metabolic syndrome. So metabolic syndrome is dysregulation of metabolism leading to dysglycemia, hypertension, obesity, and non-alcoholic fatty liver disease. So when metabolic syndrome, which is a part and parcel of future tragedy, occurs, this is what happens. And these are the ingredients of metabolic syndrome. So if diabetes occurs with obesity, it's known as diabesity. And if diabesity occurs with metabolic aberrations inside the cellular milieu, including mitochondrial dysfunctions, this is known as metabesity. So metabesity refers to metabolic aberrations associated with obesity, along with a genetic component. The phenotypes in metabesity are largely the result of sedentary lifestyle and unhealthy eating habits. And this is what the drivers of metabesity are: hypertension, diabetes, fatty liver disease, etc., etc. There are people who come to us and say, our labs are normal. So what if we are obese? So these people are known as healthy obese. So do they carry risk? Yes, they do. They do have a risk, although their risk factors are lesser as compared to those people who have got bad metabolic profile. But if these patients, they remain obese without any bad metabolic aberrations in their lab markers, even then they have a little bit higher risk as compared to those who are thin and lean. But if the patient also has non-alcoholic fatty liver disease, that healthy obesity automatically gets transformed into unhealthy obesity. So in metabesity, what the underlying problem is, there is an inter-organ crosstalk. And there's inter-organ crosstalk, which I'll be just moving around quickly, that there are people who have got deranged myocardial metabolism in obesity because the substrate shift from fatty acids to glucose, the inability to do so, and that can cause ischemia. So this inter-organ crosstalk between obesity and cardiovascular disease does play a role. We all know that there is cardiac fibrosis and diabetes. Again, an inter-organ crosstalk. So the crucial aspect is adipositis. We all know that the fat cell or adipose tissue is full of inflammatory markers. It's full of adiponectins, cytokines, which are released, and when they're released, they cause destruction. And that is responsible for, that acts as the key regulator of systemic dysfunction. There is immunoinflammation metabolic crosstalk. I'm sorry, so we need to move ahead. So there's cardiorenal crosstalk as well. We all know that heart and kidneys, they are married together. They are not independent. If you have ischemic heart disease, we have ischemic nephropathy. If you have diabetes, we have got diabetic nephropathy. So they all work in concert, meaning thereby they have a cardiorenal syndrome. So we just move forward, cardiobesity. We know obesity it brings endothelial dysfunction, coronary calcification, which ultimately leads to complications like type 2 diabetes, atherosclerosis, hypertension, hyperlipidemia. If you look across all the phenotypes of HFpEF, the one thing that will stand out is obesity. Whether it be any parameter like atrial dysfunction or pulmonary dysfunction, the underlying bottom phenotype that will be common in all cases will be obesity. And we know that the metabolic implications of obesity are NAFLD, cancer, aging, all these things, they are the result of these consequences of obesity. So we have the data from Look Ahead clinical trial that caused chaos by telling us that if we lose weight, if we become healthy, we'll die lesser of cardiovascular morbidity and mortality. And these are the benefits of weight loss, is associated with improvement in metabolic and cardiovascular health in obese individuals. And the dictum that we have under this roof to decrease the incidence of cardiovascular disease by 30% by 2030 can only hold true if we work and target the core problem in our population, that is bad lifestyle, bad diet, and obesity. And we should target the metabesity and target the obesity, target the underlying causes that cause obesity. Just 3 or 4 slides left. This is the example. Neither do we want to become a bodybuilder like this, nor do we want to become a patient with anorexia nervosa or those fat, late chubby ladies. So BMI is out, waist-hip ratio is out. Updated NICE guidelines tell us that you can easily gauge the health of your patients by observing the waist-height ratio. So if your patient has a waist-height ratio of less than 50%, he's healthy. You can see that in this picture. These are the 4 individuals. The person with the 0.47 and 0.38 are much healthier. And as we move from 0.5% up, we have higher incidence of cardiovascular morbidity. How do you manage? We know by losing weight, by just 5%, we can cut down the risk of hypertension and hyperglycemia. If we go to 15%, we can cut down the risk of cardiovascular disease. And if we reduce our body weight or body fat by more than 15%, we can cause remission in type 2 diabetes. We can cause decrease in cardiovascular mortality and heart failure. So this is the classical 7 of the AHA. Everybody knows about it. The 8th one is missing. The 8th was sleep. So 8 has been also added up. And we have got so many medications for those, for controlling metabesity. We have got SGLT2 inhibitors, we have got GLP receptor agonists, we have got drugs like orlistat. So this is basically polypharmacy that deals with it. And we can do that by, of course, following weight loss, non-pharmacologically as well. Because our ancestors were thin, our ancestors used to be happy. So let's work together to control this epidemic of obesity. Let's work together to get rid of this weighing scale, जहाँ पर हम किलोग्राम नहीं करते, हम देखते हैं कि बच के बराबर वजन है कि मुर्गे के बराबर वजन है. Why? Because you cannot wish for both strong character and easy life. The price of each is the other. I work on the raw set principle. This was the guy who started the raw set. He was metabolically obese, 99 kilos, and he had acanthosis nigricans, fatty liver, everything. So he started working on the principles of health, in trying to improve the health span rather than lifespan. And then he started working out, and this is how he changed. So this is the power of exercise, which I can say sheer power of exercise. If he can do it, you can do it, everybody can do it. And I tell my patients, exercise is king, nutrition is queen, and if we have both of them together, we have got our own kingdom. Some people feel the rain, others just get wet. So follow that dream, so gentlemen. And yes, metabesity is a fact. Thank you very much. Any questions? Sir.
Just a comment. I am a pediatric cardiologist working at a Children's Hospital, Lahore. And this very really alarming that in my clinic or my hospital, what I see that more than 30% of now my kids of O-level, A-level or metric, they have developed hypertensions. And 80% of them are obese.
39 million Pakistani children are obese. 39 million. This is the solution for it. हमारे यहाँ पर सर मसला ये होता है जब बच्चा पैदा होता है बच्चे मोटे होना कहते हैं क्या जबरदस्त पेरेंट्स हैं क्या पाले हैं बच्चे और अगर दुबले पतले बच्चे हों कितने माड़े पेरेंट्स हैं ख्याल ही रख दे मुंडे आदा
नहीं he is absolutely right कि इसका हल क्या है देखिए मसला ये this is the educations हमारी educations ये है कि हमारे पास आते हैं कि बच्चे मोटे नहीं हो रहे हैं बच्चे पतले हैं I routinely what the complaint parents have with us कि जी मेरे बच्चे मोटे नहीं हो रहे मैं हमेशा उन्हें ये कहता हूँ कि मोटा बच्चा बीमार है थिन बच्चा हेल्दी है और सेम इज विद द फूड और खासकर ये जो 3 साल के कोविड ने ना हमारी जो हैबिचुअल और लाइफस्टाइल चेंज की है खासकर यंगर में दैट वाज अलार्मिंग
ट्रू
सर मैं किसी कमेंट दूं आई मीन हम सारों की ना मुल्क समेत हमारी थॉट्स डिस्टॉर्टेड है मतलब ये सारे यहाँ पे कार्डियोलॉजिस्ट बैठे हैं इंटरवेंशनल कार्डियोलॉजिस्ट बैठे हैं पीपल कम टू अस से यार आप स्टैंड डालते हैं आपको प्रिवेंटिव पे काम करना चाहिए प्रिवेंटिव पे देखिए हमारा काम इंटरवेंशनल कार्डियोलॉजी है वी डील विद आवर पोर्शन ये सरकार का काम है कि वो बाकी चीज़ें कवर करें ना। अब हम छोटे थे तो टेलीविजन पे कितने इश्तिहार आते थे ऑन हेल्थ कि दिस गाय ईटिंग बर्गर टक्कर मार रहा है, आजकल कितने आते हैं। द सरकार हैज टोटली लॉस्ट इट्स गेम, दे आर नॉट डूइंग एनीथिंग इन पब्लिक एजुकेशन एंड दिस इज व्हाट इज रिक्वायर्ड हियर। ये मतलब आप छोड़ें कि आप सिद्दीकी साहब या खुरम साहब या जैन लाजर क्या नहीं करेंगे, तो को आप एक मरीज को बताएंगे, लेकिन ये पब्लिक एजुकेशन है, अवेयरनेस है, इट हैज़ टू बी इन्वेस्टेड। ये डॉक्टरों के बस की बात नहीं है। जैसे वो चर्चिल ने कहा था ना कि वॉर इज सच अ सीरियस बिजनेस, इट कांट बी लेफ्ट टू द जनरल्स। तो आप मुझे बात तो कर रहे थे ना
सर।
सिमिलरली
Sir, I think in the interest of time, we need
Sir,
to
just
move
file
forward.
comment. Sir, ruk jaye.
Before this,
And
that
sir,
everything
sorry,
comes to
sir,
journals,
नहीं.
I think we need to move forward.
देखें, आपने अगला मिसरा नहीं सुना ना, आपने अगला मिसरा नहीं सुना ना कि health is such a serious business, it can't be left to the doctors. Really, doctors का अपना एक काम है ना, हमारा काम तो जो आएगा हम नहीं
Sir
करेंगे।
Suhail, it's
So
an
please
excellent
educate.
statement.
Thank you, sir.
And we buy that statement, and I think all the talks were excellent, a message was great, and I think we should continue our efforts at least. And I think we need to not only work in the hospitals and clinics, we need to come out and go to the public, and we must go for mass communication and should keep imparting all these issues and remedial measures. Thank you very much.
Thank you, sir. Thank you very much.
Thank you so much, Dr. Rehan, for such engaging and thought-provoking, and what a great transformation we saw in the last. There's a short announcement I want to make. There is a parallel session on atherosclerotic cardiovascular disease in Bourbon Hall. Those who wish to join can join. And that brings us to an end of this session. I'm really very, very grateful for our chairpersons, panelists, and our presenters, speakers for your valuable time and patient listening. Thank you so much.